Welcome to TTAPS Part 3E. Now, a lot of this stuff is taken from a lot of varied sources. I'm going to quote first out of Modern Manual Therapy of the Vertebral Column by Gregory P. Grieve, FCSP. Now, basically it talks about the gliding motion of joints and how when you don't have the gliding joints then you run into troubles. So aren't we as chiropractors basically just restoring motion? So if we don't have the proper gliding motions, we are restoring that. And if you remember back in the ribs in Capangi Volume 3, the trunk and the vertebral column, page 134 to 5, rotation of the thoracic vertebra subjects sternum to shearing forces. So Capangi views the whole thoracic cage as a unit. So when something goes wrong with the thoracic vertebra, then it affects all of the ribs, even around to the sternum and vice versa. And for example, I had a female chiropractor call me up excitedly, had a patient years before it had a house fall on him and survived, and everybody had gotten rid of everything but the thoracic pain. She said, I did your rib cage protocol and the thoracic pain went away. So keep that in mind. Everything is related one to another. Now, here it says the neck. Pain is commonly referred into the upper thoracic region outside its confines, i.e. from the lower three cervical segments. This is from Cloward, 1959. So even in the medical area, they realize that the cervical area can affect the thoracic area, and also therefore the opposite direction too. And here we have Lindahl and Hamburg, 1981, state that pathological changes in the esophagus, mediastinum, and thoracic spine can produce chest pain, which is equal to that of angina. The authors mention that sympathetic nerves to the heart are derived from segments C3 to T6, and stimulation of these can result in pain experienced in the root of the neck, upper limb, and hand, as well as the anterior chest. So there's a lot of stuff outside chiropractic that we can relate to and relate to patients that supports chiropractic here. Now the diaphragm attaches from T5 down to L3. So basically, if you have a problem with patient breathing, you may have to go as low as L3 to affect the diaphragm, which a lot of us don't even think about, but you have to look at that whole range of connections and all the ribs in that area as well. Abandoned headache syndrome. Here it talks about this physical therapist that had people who've gone to chiropractors, couldn't get rid of the neck pain, so they mobilized the neck and got rid of the neck pain. So we're going to be talking about that. Cervical headache. Brain, B-R-A-I-N, in 1963, suggests in relation to cervical spondylosis that headache is one of the commonest presenting symptoms of cervical spondylosis. So here they're recommending taking and adjusting, mobilizing, manipulating the cervical area for headaches. T4 syndrome. T4 syndrome, you have pain in the cap, in the hands, elbow through hands, or shoulder through hands. And here's the picture of it right here. So if you've never thought of the T4 syndrome or even knew about it for those particular symptoms, there it is. Now, fibrous ankylosis is a fibrous connective tissue process which results in decreased range of motion. It can proceed into bony ankylosis, so it can proceed into fusion. So the whole point of adjusting, manipulation, mobilization is to free up the fibrous ankylosis, break up that scar tissue in the joint and around the joint. And the very first part of part 3, we talked about positions of restrictions. That's compression, distraction, rotated right and left, flexed right and left, anterior superior glide, right and left glide, distal to proximal, proximal to distal glide, and vectors of glide. You do it in standing, sitting, prone, supine, side posture, or prone on a stool, which we're going to get into those. So here we're going to start out after this brief introduction of how to take care of compensatory subluxations, which is the next part, and we're going to go right into the cervicals, where you're going to learn vectors of glide, and we'll be able to show you how to do that throughout the vertebra. Okay, we're going to look at the throat here. This relates a whole lot to the cervical and upper thoracic area. Here you have the hyoid bone. We'll be showing you on a model here in just a little bit. You can actually adjust that, and directly below it you have the thyroid cartilage, and you have the cricoid cartilage, and you have 3 tracheal cartilages. So those are going to be the things that we're going to adjust. Now, one of the findings with this is not only does it help the pharynx and the larynx, it helps the epiglottis, which attaches to the hyoid bone. It helps the tongue, and there's a lot of muscular interactions, say with the jaw area, for example. The jaw and the digastricus attaches to the hyoid and up to the mastoid bones. You're going to affect the TMJ, and guess what? The underlying structures of the thyroid and the parathyroids. And I pointed this out in a class, and a doctor immediately went home, had a patient come in that had just a week before been put on thyroid hormone, and he had time to adjust her once, so he thought, oh, I'm going to try this on her. So he adjusted all these structures of the throat. Her and her husband went to Hawaii. Then she went into thyroid storm. She goes into an ER, and the doctor checks her thyroid, and he says, why are you on this thyroid hormone? You don't need it. Got off the thyroid hormone, and her thyroid was normal. So basically this can correct the thyroid and the parathyroids. So it can correct the voice box, the esophagus, so you can have swallowing, choking, gagging, for example, can be corrected from this area, as well as the thyroid and the parathyroids and the TMJ, and et cetera, and then you get into the lower areas, and so you can help correct asthma and bronchitis and things of this nature. So there are a lot of things that can happen from this area. Now, what else attaches that hyoid? The tongue attaches to the hyoid. So here we have the tongue. So just the very act of swallowing and articulation can be affected by adjusting that hyoid. And because there are muscles that attach the hyoid to the thyroid, for example, adjusting that thyroid cartilage can affect the hyoid, therefore affect the tongue and articulation. So there are a lot of things that can happen from this area. Now, on top of that, all these muscles that interact between all these cartilages and the jaw and the mastoid directly oppose the muscles of the cervical area. So because of muscles between the hyoid and the jaw and the mastoid, and between the hyoid and the thyroid, the cricoid, and the 3 tracheal cartilages, those muscles have a reciprocal innervation with the cervical vertebra and their muscles. Therefore, when you correct the things on the front, it's going to affect the back. And so a lot of neck pain and tightness that is evaded a lot of people, you're going to correct by adjusting, manipulating, and mobilizing these structures. The hyoid bone sits up under the chin here. Basically, you want to view adjusting, manipulating, and mobilizing the hyoid and the throat cartilages just the same as any articular surface. Basically, you want to take it to tension, full tension, and give a light thrust. So for example, we'd take the hyoid from right to left like so and tap it to free it up. Thyroid, cricoid, first, second, third tracheal cartilages. And you would do the same on the other side. You would do the A to P, you would take it to tension, A to P, and thrust one side and then the other. A lot of times you will get a resounding osseous clunk, a cavitation. Also, you want to take it from posterior to anterior. So you would take and pull. So I'm showing you here how you get behind it and pull forward. I'm going to hook like this, and I'm going to pull forward and tap from P to A, just like this, for all those structures. You can also do a catty corner, like this. Take it from superior to inferior, one side at a time. So you're going to drive upwards here and downwards there. Take the tension, thrust, 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 like that. And in the opposite direction. And this gets amazing results. And just like I gave the example with the doctor with the patient with the thyroid, she went into the thyroid storm. They had to get her off the thyroid hormone because it corrected the circulation to and from the thyroid gland, took the pressure off the nerves, corrected the lymphatic drainage, and the thyroid started functioning properly, so she no longer needed the thyroid hormone. And we've seen this over and over. And here we're going to talk about distraction and compression. So when vertebrae are compressed in the cervical area, we've all had the Turkish towel move where you wrap a towel around and you have the guy doing the ring dinger from Houston. However, those are general and they have their place, and I don't doubt that. However, I thought because they're general, maybe sometimes we need to be specific. So you take your middle fingers just like this and you get under the spinous process of each vertebra. And you can start with the occiput and you pull it to tension to see if it has that paraphysiological give or if it hangs up. So you have the patient lay with their neck lightly relaxed backwards and you're tractioning and you're feeling if that particular vertebra hangs up. And here we have a second cervical, boom, just like that. And it releases. You can go all the way down the cervicals, maybe to the first, maybe even the second thoracic that way. And a lot of times when you do this and you take the traction, the patient will feel the L5 decompress off of the sacrum down there. That's not unusual at all. So you take it to full traction, just give it a slight quick impulse into distracting move, and it does that. Now I had a female come in once that was having severe pain in her shoulder and her arm, and nobody was able to get it, and I tried everything. And then I heard an angel whisper in my ear, maybe it's distracted. So I started thinking, well, the vertebra may be wedged on one side, say distracted. So I would want to compress it. We normally think and have been taught about decompressing vertebra. And so I thought, well, I'm going to try that. So basically you take on the lateral body right where the transverse process hits with your index finger, and you're going to kind of cock the head to the side like this, and you're going to feel whether there's any give and if the vertebra collapses on the vertebra below or if it hangs up that way. And if it hangs up, then you take the tension and you thrust it, and it's a thrust basically toward the opposite heel. Soon as I did that, and it had a big cavitation, which you don't always get, she said, "Oh, finally somebody helped." Immediately it got rid of the pain and paresthesias going from the neck all the way down into the fingers and hands. And so this can be very, very good type of thing. Now I had a power lifter. He weighed about 135 pounds, very slender, very small, and he had gone to a powerlifting meet and squatted 450 pounds, full squat, in competition. He came to me and he says, "Oh man, I'm dying." He had pain shooting out from his neck into his shoulders and arms down his hands. I tried everything I knew, trigger points adjusting, compression, distraction, all sorts of things. I couldn't find anything, and I thought, what am I missing? So I went back and I looked at the x-ray, and I noticed he had a Spina-Bifida Occulta, and it was either on C7 or T1. And Angel whispered in my ear and said, "Adjust those inwards." So basically you have a split, and instead of it ossifying where the spinous process would be, you have cartilage there. So I took a compression on both sides and I pressed, took it to tension and thrusted, and I mean it was a loud cavitation. And he sighed and he says, "Oh yeah, that got it." So it's the only case I've ever seen like this, and I've never seen this described in the literature, but you may see somebody like that either in the lumbar or the cervical. So there it is. Here we're going to talk about the atlas and the occiput. Now, basically, you want to palpate, so you're going to, I like using my middle finger, you probably use your index finger. You're going to put it right behind the jawline. You're going to take it up right in front of the mastoid. So you're going to be between the mastoid and the jawline. And with the tip of your finger, you're going to rotate. On the tip, you're going to feel the transverse of the atlas. And the atlas should open up just slightly like this on both sides. Now, if it opens real wide, that means that you need to adjust the atlas forward because the atlas is toward the back. If it doesn't move at all, that means you need to adjust the occiput forward. So, for example, if the atlas was on this side and I was using the Gonstead style, I would take my thumb and I would put it on the back of the atlas, and I would have the patient laterally flex and rotate and lift the head up. So extend, and it's a straight thrust. This is what I call a vector thrust. And so you lock it out in 3 positions: lateral flexion, extension, and rotation. And as soon as it locks in all of them, it's a straight thrust without rotating. So to do that on the occiput, you cradle the occiput in your hand like so. And now I'm doing this on the other side. One thing you don't want to do is hold the head like this, because that makes the patient uncomfortable. When you're kind of covering the ear and the fingers are going down the side like this, makes the patient a whole lot more comfortable. Now you can do the same thing in a pull move. What counts is the point of contact and the line of drive, and making sure that all the vectors are locked out. And so it doesn't matter what technique that you use, those are the important factors. I like doing this Gonstead more than any type of thing. Now Gonstead occiput move is like this. I never was real good at that, so I had to figure this out. So basically you lay the occiput in the hand here and you cup it and you lateral flex and you extend and you rotate and you feel till you feel it lock out, and then it's a boom, straight through thrust. Just to give an example, when I was in Michigan, there were 3 chiropractors grown up together, went to chiropractic college together. They all lived in the same area. None of them had been able to adjust each other's atlas and occiput, and they'd been to a lot of seminars together. I came to this point and they said, "You're not going to just be able to adjust this. Gonstead practitioners, everybody's tried it." I said, "Okay, coming up." I got an osseous clunk on every single one of them. They couldn't believe it. They came up one after the other and doing it just like I described help. Now, one of the things that I do differently from everybody, instead of saying relax, 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 I have the person help me get in the position. That way they automatically relax. So instead of saying drop your shoulder, look at the fly on the wall, anything like this, you say tilt your head this way. Lift your chin, rotate this way, tilt more, rotate, lift up, tilt, till you hit that one spot and then you thrust. Now I've taken care of 12 professional sports teams, 3 of them foreign national, and all sorts of huge people that nobody's ever gotten their cervicals to move. And it just drops right in. They say, "I can't believe it. I've had huge guys, huge chiropractors trying to adjust it, physical therapists, and nobody could get it, and you did it so easy." That's because I've recruited them to help me. And I use this vector type of approach, okay? Now you use the same thing all the way down the cervicals. So you take a contact, for example, with this, Gonstead style, and you say laterally flex, lift your chin, rotate, and you keep going until everyone locks out, and then you have a straight thrust. So here you discipline yourself all through the cervical area in the occiput to have somebody help you into the position and lock out all 3 vectors and do a straight thrust rather than use rotation. So that takes a lot of discipline because we're not taught that way. We're taught to rotate at the same time. And you will start getting miraculously easy results with people that you always had trouble adjusting their neck. Huge people. It doesn't take a big person to do this either. When you recruit them to help you and you lock out all the vectors totally and a straight through thrust, it goes very, very easily. Now we're going to talk about anterior cervicals. You're going to have some people that you just can't get the cervicals to release. And they're having a lot of pain. You're just not getting to the basis of it. You've corrected the ribs and all that. Well, it's most likely anterior cervicals. Normally when it's anterior cervicals, you press down here in the lower scalenes and they're going to have a lot of pain down in there because the scalenes come down and they attach to the first and second rib. Now, anterior cervicals, you palpate in a different way. So I like palpating with my thumb, for example. So I put it on the anterior of the transverse process. I'm pressing backwards. You're going to feel it stop in the restriction, say right here. You keep that pressure on it, say if your thumb, you instruct the patient to hold their head in that position. Just take your fingers, tap it maybe 3 times sharply, and it frees right up. You can go immediately back to the lower scalenes and the pain is gone. So it's very, very simple. Mobilization has profound effects on chronic cervical pain. Dr. Alf Brieg, a Swedish neurosurgeon and Nobel Prize recipient, coined the term adverse neural tension to describe the mechanism by which loss of normal cervical lordotic curve creates dysfunction and disease. Through cadaver studies, Dr. Brieg demonstrated that neck flexion could stretch the spinal cord 5 to 7 centimeters, causing tensioning of the meninges, which covers the brain and spinal cord, and elicits measurable pressure on brainstem nuclei, nerve control centers, which control all basic life functions. The increased compression led to dysregulation of metabolic control functions. Recall that the spinal cord is actually only tethered to the bony skeleton in the upper cervical and the lowest sacral and coccygeal areas, the upper and lower areas of the spine. In between these polar attachments, the spinal cord is relatively free to move up and down. Free-floating mobility of the cord is essential in allowing bending and twisting of our bodies. Anything that reduces that freedom, i.e. exaggerated or flattened spinal curves, dural impingement, etc., increases cord and brainstem tension. Increased tensile stress on the cord and brainstem not only interferes with the control of basic body processes such as breathing and motor control, but in cases of dural impingement may encourage painful cervical radiculopathies. So basically, a Swedish neurosurgeon says that you need the neck curve in there, and it can cause you really severe problems if you don't have it. Now, Kapandji, The Physiology of the Joints, Volume 3, the trunk and vertebral column on page 20 says the curvatures of the vertebral column increase its resistance to axial compression forces 10 times that of a straight column. So that is, speaks for itself. So a proper curve in the neck, most especially, is very, very necessary for health in many different ways. The anterior and posterior longitudinal ligaments are interlinked at each vertebral level by the intervertebral disc. The annulus fibrosus is made up of 7 concentric layers that are vertical on the outside, then cross each other and progressively become more oblique going internally. The central fibers in contact with the nucleus pulposus are nearly horizontal. So basically, the nucleus pulposus is a swivel, a ball between 2 planes allowing tilting, which is flexion, extension, and lateral flexion, rotation, gliding, and shearing of one plateau on the other. Axial compressive forces are 75% on the nucleus, 25% on the annulus. Now, basically speaking, there are a couple of different things that you can do to regenerate a disc. One is imbibition. The nucleus rests on the center of the vertebral plateau, an area outlined by cartilage, which is transversed by numerous microscopic pores linking the casing of the nucleus and the spongy bone underlying the vertebral plateau. So this can happen basically in any joint the same way. Standing causes the water contained within the gelatinous matrix of the nucleus to escape into the vertebral body through pores, causing about a 2 centimeter, almost an inch loss of height regained at night. So one of the things that you need to take from that is, I'll give you an example. I had a young man, he was 5'11" and a half. And he came in to me and he says, Dr. Bromberg, I don't know if you can help. I heard that my growth plates are fused, but I really would like to be over 6 feet tall. And I asked him, I said, well, when do you measure your height? He said, well, usually at night, like 8, 9 o'clock. I said, okay. So I went over and I put my hand on his head and I tapped him like that. He said, when you wake up in the morning, go measure yourself. He called me up, he said, I can't believe it, I'm 6 feet and a half inch. He said, how did you do that? And I said, oh, I have magic fingers. Now most patients basically know that you grow an inch at height. They don't know that it's a process called imbibition. That's one of the ways to look at it. So basically, when you free up the fibrous ankylosis of a joint, you take away the compressive forces of scar tissue. Remember, scar tissue as it ages, it dehydrates and shrinks and compresses. You take away the trigger points, which you have hypertonus in the muscles, also cause the compression. And you're adjusting for the fibrous ankylosis, you're breaking that up. Now you can get this imbibition and rehydration. So that's one way that you can regenerate a joint. Another one is that the disc itself is non-living, but the chondrocytes in the disc are living. The chondrocytes are stimulated, and this is in your notes, you have all the documentation there. The chondrocytes are stimulated by motion. So basically, not only can you increase the size of the joint by imbibition, by freeing it up, and this is any joint, but in a cartilaginous joint in particular, you can regenerate the cartilage because you reinstate the motion, and the person motions that joint every day, and the cartilage starts to be produced again. One other thing is that because of the piezoelectric effect, normally when you look at a bone that's cut through the shaft, say a long bone, you see all these striations in there. Those are put there by the piezoelectric effect. And basically this was brought to the chiropractic profession by Burl Pettibon. And basically, whenever you use the muscle, an electron shoots through into the bone at the angle that the muscle pulls. And then it's chased, because it has a negative charge, it's chased by a positive calcium ion, and this is what causes calcium deposition in the bone. When the joint limps, then instead of going into the bone, it reflects off of the bone. The body is still looking for this homeostasis, so the calcium still chases it, and it forms an osteophyte, or a bone spur. So basically, in your class notes, my thesis done with the American College of Sports Medicine in 1985, and I was the only chiropractor who had a paper accepted out of 655 papers. They sent me a note, which I still have, which is pretty cool. One of the things that was noted in there is that we took somebody with a totally fused joint, not only in a 63-year-old, not only did we unfuse the joint, but gradually built it up to full capacity in the joint. Went from no movement to full movement and full strength. And it had joint effusion, which you could see on the x-ray. Joint effusion went away. It had a huge spur, and the spur over a year and a half went down to a fifth of its size. Now, Pettibon demonstrated that on before, intermediate, and after x-rays in the vertebra. As far as I know, I'm the only person ever to demonstrate it in extremities. But it took the same principle, which is the piezoelectric effect. So basically, you can regenerate a disc in two ways, and you can regenerate non-disc joints still with the imbibition and cause that joint to rebuild up with motion. One of the things that we want you to note with the rotation of a vertebra, whenever you laterally flex the vertebra, and the vertebra rotates one way in the cervical area and the other way in the lumbar area with lateral flexion. And one of the reasons that you have the recurrence of the subluxation is that you don't take care of the lateral flexion. So as we go through this film, you're going to notice that I talk about distraction subluxations, where you actually have to compress the joint. We're taught to uncompress the joint. But in these cases, you have to compress the joint because it's stuck in distraction. We really are not taught that. And when you do that, and you're correcting this lateral flexion, and then the rotation can occur, okay? So this is a way to correct those chronic subluxations. Now, several docs ask me, you know, they say, I keep having a problem with the patient because I can't get the rotation back in the neck. And I ask them, well, what area are you adjusting? And usually it's like, well, I'm adjusting C5 and C6. Well, basically 85% of the rotation occurs occiput C1, C2, C3. So I just tell them, you're adjusting the wrong area if you're looking for rotation. So once I get that through their head, immediately they start seeing an increase in the rotation. So if you're looking for an increase in the rotation, look toward the upper cervicals. It's basic anatomical distinctions that you're looking at here. Now, the upper thoracic and the lower thoracic can be particularly difficult to move. And a lot of us, almost all of us, are taught to thrust straight P to A with maybe a twist in it. Maybe crossing the hands like so, maybe going like this. Well, basically, to get it to move easier, you want to follow the plane of the disc. So the back curves posterior at the thoracic and then anterior at the lower thoracic. So posterior from progressing from the upper thoracic to the middle, and then anterior going down. So instead of adjusting straight down, you would want to adjust here, 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 and then there, 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 at different angles with the disc. If you do this, you're going to find that they move so much easier rather than going just straight P to A. And I know Gonstead teaches to thrust headward, and I've had a lot of people that didn't work on, and I did it just the way that I described and they moved real well. And what Gonstead does is he said, well, you're going to distract the vertebrae and decompress them. And that has some benefit, but it also has a benefit when that doesn't work to adjust with the plane of the disc. Now we're going to go down to T1 and T2 in the sitting position. And basically, in the cervical area, we're taught a corkscrew maneuver. When the person is face down, you're blocking the spinous process on one side with your thumb, and you rotate the head the opposite direction, and it's a counter thrust. So the thumb thrusts this way when you lock it, and the head is thrust the other way. Basically, that's the same way that you do this. And traditionally, T1 and T2 are very difficult to move for most chiropractors. This is an easy way to do it, but there is a caveat too. And you stick your thumb in there and you block that spinous process, but with this, you're going to rotate that head, and the neck, your head may be totally rotated away. It may be in any position, as well as looking straight toward the same side before it locks. We're used to it being turned the opposite direction. So basically, you have the patient help you. You drop the head back into extension and you rotate until it locks, and right there on this particular patient, and it drops right in. So T1 and T2, this is a very easy way to get those two segments to move. Now, the same blocking, you can do this in a seated position all the way down to about T8. Basically, you're going to take the person's head here, and you're going to use the head and neck as a lever. You're going to block the side of the spinous process, and you're going to use it as a lever down there, and your thumb is going to be the fulcrum. And you can laterally flex and rotate all the way down to T8, you get spectacular moves that you can't get with the patient prone or on their side just by doing this. And it's amazing to do it. When you start doing this, you're going to be oh so happy that I showed you how to do that. Now let's talk a little bit about anterior thoracics. Gonstead said there is no such thing because there is a physical barrier there. And I agree with that. However, that having been stated, one thoracic can adhere to another one and keep it from going posterior. So from that standpoint, you can have two thoracics adhered together, preventing another one from going the other way. So you can have a relative anterior thoracic, and that's why anterior thoracic adjustments can be made. All right, this seems kind of odd because I'm saying to adjust difficult upper thoracics on a bar stool. My father, when I went home one weekend, I hadn't been home for about 4 months. I went over to my aunt's house right across the street, and they said, "Have you been home yet?" And I said, "No, you need to get over there. Your dad's really bad off." And my dad was 71 at the time. So I go home and I walk in the front door and my mom says, "You need to go see your dad right now." Well, my dad's face was very white and he was very sick, and his head was lurching forward, and I'm going to go down like this so you can kind of see it. His head was lurching forward like this. I said, "Dad, why is your head so far down?" He says, "Well, if I try to lift it up at all, my right thumb goes totally numb." So I looked at that, and my brother is a chiropractor. We went to college together, and my brother-in-law, and he's a very excellent, one of the most excellent Gonstead practitioners I've ever seen. He's very dedicated to it. He wasn't getting anywhere with that, and so I couldn't get anything to move, and I thought, how can I get this to move? Angel whispered in my ear, "Get out of Barstool, have him drop over it." Now when you do this, you're going to have the person drape the shoulders over the sides and make the throat so it clears the table, because you're going to thrust with the discs this way. There you go. So you make sure that the throat's clearing the table. Now this opens up this upper disc area, and I took my hands like this and just made a solid contact and thrust it, and it gave and it adjusted. Now you're going to find that when you do this, it really makes it easier to adjust all the way up down to maybe T6, but it will help you to release especially T1, 2, and 3 in ways that you've never been able to before. Now, before I left, I showed this to my brother-in-law in his office about, a mile from where my folks lived at the time. And I said, "You got to get Dad over there a couple of times a day. Bring a bar stool home and, if possible, adjust him there." So he did, and he adjusted him a couple of times a day. Next time I see Dad, a few months later, I get home, and he was standing straight up, and I said, "Dad, how's your thumb?" And his color was normal and everything. His energy was back. He tilted his head real far back, and he had no slouch whatsoever. He says, "When I take it way back here, I can feel the tip of my thumb tingle just a little bit." Now my dad lived till 98 and a half, so he lived another 27 and a half years after that. This adjustment and putting him on distilled water, I think, were two very crucial factors in doing that. And I've used this on difficult cases ever since then. When I was in undergraduate school, between semesters, over the summer, over the winter, I would working a beef packing plant, and I would lug beef, and we would carry anywhere from 250 to 450 pound quarters of beef on our back. And one, you would run under the forequarter and somebody would cut you loose with a knife, and then it would trolley down and you would get under it and you would lift your shoulder and they would pull the hook out and you would run in. Then you go in and drop it on a hook on the inside with somebody helping you. So this one time I had about a 450 pound hind quarter, and I got up under it, shrugged my shoulder and took out running. The guy wasn't paying attention and he didn't unhook it. So I jammed really hard in my middle back. I thought I was going to die. So they sent me immediately to an orthopedic surgeon. He x-rayed me and said, "Oh, there's nothing wrong. I don't see anything." Man, I was about to die. Felt like somebody was sticking a dagger in my middle back, about T4 area, basically, okay? And so that night I got on the carpet on the floor and I thought, man, if I just rotate that. So I put my shoulder on the floor and I just rotated and kicked and kicked and kicked, and I felt that pop and it dislodged and I felt great, okay? So I've never seen anybody do this. So, but I always carried that with me. So in difficult middle thoracics, and this can rotate T2 basically all the way down, and we're taught the pull move in the lower back, but I just apply it all the way up, and I found as high as T2, but normally it's about T4. And so basically what you do is you shove that shoulder back as far as you can and put a rotation on, and you rotate the hip. And you take your tip of your middle finger and you put it on the spinous process, and you counter thrust forward this way and down this way, and it boom, and it gives. And this gets some miraculous releases, and I've done several of these on chiropractors in the seminars that I give. They go, "Oh my gosh, nobody's ever been able to get that area before." So this is the very difficult area between the shoulder blades that we as chiropractors have a lot of difficulty with, and this is a very good way to get a lot of those from a rotational aspect. Now in the lumbar area, the only thing that I'm going to show you basically from here before we hit the standing posture is when you have asymmetric facets. Now in asymmetric facets, one is sagittal and the other one is like this. So you're going to go like this and like this. And what you're going to find is when they're pressed together, say on the left here, like this, if you try to adjust into it, it's not going anywhere, but you adjust away from it, then it will release. One of the key findings is that just below the 12th rib on the opposite side really hurts. So you get these patients that just dog the heck out of you. You adjust that 12th rib, you're adjusting T11, 10, 11, 12, L1 and 2, you do all the ultrasound, the electrical stim, you do the trigger points, nothing breaks it. Well, guess what? The quadratus lumborum attaches to that 12th rib, the spinous tips of all the vertebrae, except the 5th vertebra, which attaches to the iliolumbar ligament and to the quadratus lumborum. And that's what's the magic of this. So basically you're going to do a straight across thrust. Here, instead of rotating the shoulder back, you're going to push it straight up. You're not going to rotate the pelvis down. You're going to take pisiform contact on the mammillary process of L5, And so you're going to stretch it out, and you're just going to do a body drop with your arms straight. It'll release, and immediately you can put a pressure up under that 12th rib on the opposite side, and the pain is gone. So what you've basically done is adjusted this part away on the asymmetric facets. Now we're going to talk about the sacrum and the coccyx. Basically, I'm not going to try and reteach you how you already know to do it, but what I'm going to say is basically you palpate here, just like this. If there's a hang-up, for example, and you may not see that, but you'll push here and it won't move, whereas the other side it will. So basically you take a firm contact and then it'll move, and it's just that simple. And the sacrum fishtails like this, so you can adjust the upper part, the lower part. This, for example, on this subject, it moves easily this way, doesn't move so easily this way. So you take a contact like this, now it moves easily. Coccyx, same thing, it fishtails. And it's hung up moving this way, not that way. So we're going to take a firm contact, just like that. Now there's some movement. You can go P to A. Now on the tip of the coccyx is going good, but on the apex, but on the base it's not so good. So we take a firm contact, now we got a little bit of give there. We go to the sacrum on the sacral apex, not a whole lot of P to A movement. Just like that, now we have give, and it can be one side or the other or the whole thing. We go to the base of the sacrum at the top, and it can be hung up on one side of the boat or the other one. You take the tension, you give it a couple of slaps, and it moves. Same thing on the innominates, just like this. So you're going to push P to A on the PSIS. This one is a bit hung up. Actually going a little bit inferior to superior. Going superior to inferior, it has movement here but not there. So you take a downward posture, take the tension, now we have movement. You lift up on the anterior aspect, just like this. Or on this side, if it hangs up, for example, you'd pull it up here to tension, give it a couple of slaps, and you have instant movement. Now you go down to the ischium, and so you have movement inward to outward. This is hung up a little bit on both sides. Now it moves good. Now you have lateral to medial movement. You have P to A, which is good on this side, not so good on this side. So you take the tension, now you have good movement. So you don't have to lay the patient on the side. You do not need necessarily any type of drop pieces in order to do this. And you can easily reinstate the movement just like you just saw. The pubic bone, the pubic symphysis, when everything isn't in proper adjustment here, you have pain in the lower quadrants of the abdomen, basically the right and left lower quadrant from the navel down. And so what we're looking for is you have a shearing between the two. So you shear one way, you shear the other way. Then you compress them together, then you cross over, distract them apart. Then you press on one side firmly, tap it A to P, tap the other side A to P. And immediately, 10 seconds later, you go back and the lower quadrant pain is gone or essentially gone. Now, one thing I want to say about the the Coccyx, I mentioned in one class that the Coccyx, the phylum terminale attaches down to the Coccyx, so thus it can put a pressure on the brain itself, because remember the dura mater attaches to and interweaves with the periosteum of all the cranial bones. Well, a chiropractor went home and he had a patient that years before had been trampled and almost killed by a cow. And he got them all corrected, except his vision wasn't right. And he'd done all sorts of cranial moves on him and other things, and couldn't get the guy anywhere, and the guy had been everywhere. So he remembered that. So he went down and did that simple Coccyx move that I just showed you. Found a lack of motion in one motion, tapped it. The guy got up and said, "That did it, Doc." And his eyesight was corrected by adjusting the Coccyx. So you can do amazing things from this side that will affect everything on the other side. You can do amazing things that will affect the lower quadrant pain on palpation. It's very immediate. Here we're going to talk about adjusting in standing position. The way I had to learn this was that I take care of a lot of people that take care of our dogs. So we drop our dogs off and I adjust them there. Well, they don't have any tables basically, and a lot of them are, and most of them are fairly short. So basically I can adjust about anything on the neck that I could in a sitting position, and it's easier because when you're standing, the muscles aren't fighting you near as much as sitting. So I found out that I can do that, in a lot of very good ways. I can do any of the shoulders in standing, which we've showed you in sitting. Now the middle back, we talked about in the sitting position, we could adjust as low as about T8, which is about here. While standing, you can go all the way down. So if we were in this position, for example, I would tilt the head, and now we're going to tilt this up just a little bit so you can see this. I would tilt the head to use it as a lever and block the spinous process with my thumb, and we can create a vector: lateral flexion, extension, rotation, and thrust. We can go all the way down, even into the sacrum and the coccyx here, okay? And it's quite amazing, and you'll be stunned at how easy they adjust in the standing position. So this is very, very easy that way. Now the next thing we're going to look at is the pelvis. Okay, so here we are at the pelvis, and basically everything that we talked about, you can check the sacrum, you can check the ilium, you can push it, prod it, pull it, you can feel it hang up. You just take to the end of the range of motion, give it a couple of slaps, and it releases. I had this one female chiropractor, nothing we did got any relief in her lower back or her pelvis, and nothing anybody else that did at all the seminars that she'd gone to over the years. We did this and immediately released, and nothing else had gotten it. So this is very miraculous to a lot of people. Look, you can do the hip sockets, just mobilize them if you feel them hang up one way or the other, slap it, and it moves. And now I want you to take a good look at a couple of things. Now we're going to turn this patient like this. Now if you're watching somebody walk and they take a step forward, now take a step forward, okay, and it's locking up going forward, so that means that the innominate is having trouble swinging forward. So you're going to have them get in that position, and you're going to knock the upper innominate this way and the lower innominate that way. So it's the ischium forward, the ilium, the ischium anterior, the ilium posterior. So you go just like this, and we've done this many times in class, and all of a sudden the forward step is easier. It's because the pelvis wasn't rocking properly. Then you have the problem of it's not the forward step, it's the back step that's hitching. Okay, so this time it's the back one isn't going back. The first one, the forward wasn't going forward. This time it's the back isn't going back. So in this case, you would take and you would rock the upper ilium anterior and the lower pelvis posterior. So it would be just like this. We've done this many times in the seminars. And immediately their stride is longer. They're not hitching on the back side. Now there's another issue of when they're walking, let's say they're walking with the leg, let's say the right leg is crossing, the right foot is crossing in front of the left. And so what does that denote? Well, it denotes that the ilium is not shifting outward, or the ischium is not shifting outward. So you would take it and you go like that, and now the foot is tracking properly. Now what if the foot is stepping outward? So the foot is wide this time, and that's because the ischium is stuck in the outward position. So you would slap it inward like this. Now all of a sudden the legs are tracking properly. They're not stepping out too far, they're not stepping in too far. Now we're going to take a look at the knees. Here we're taking a look at the knees. Everything that we did with the knees in the laying position you can do standing. So you're going to check to see if they're in the weight-bearing position, if the, for example, the patella isn't moving right. If it's not, you take detention, give it a couple of whops, you give it a twist, just like we did on, the other part of the film clips. If the foot is externally rotated outward, like this, then that means that it's hung up between the condyles of the tibia and the fibula, so that those plateaus are hung up. So you would take a rotational contact like so, go like that, and then you would notice, turn your foot in now. You would notice it, just keep taking it around like that until it's straight. And you would keep going as it hangs up. Now the foot may be rotated inward. Here you would take it, you're slapping posterior on the outside, you're slapping anterior on the inside. You would have them rotate the foot out, keep doing it until you got that full freedom there. The knee, for example, may not be able to lock out going posterior. So you'd have them lock out as much as they could. You take the tension, you give it a couple of slaps, and it starts to free up that way. So you can do a lot of things in a standing position you just can't accomplish in other ways. And I challenge you to start working on it that way. This ends TTAPS Part 3.